When ready.
So, Greg, we were talking just now before we decided to sit down and talk about IVs with everybody about wives. And that's one thing that...
we were talking good about them.
Absolutely. And my wife, Angela, who is at home in Tulsa, Oklahoma, and she's taking care of our little buddy Jax, the black lab.
I miss Jax.
Yeah, we miss Jax. Anyway, she's like, hey, I watched you and Greg do your first tailgate session.
Nice.
And you never once mentioned me, but you mentioned that dog. So let me just start by saying, Angela, I can't wait to see you for Christmas, and I love you very much. And
yes, Mrs. Carr, and I won't put her name out. Mrs. Carr is super private. It's funny when people meet her, they're like, how the hell are y'all married? But she is the polar opposite of me, which one completes me, but two, she's everything I wish I could be. So she is definitely, well, she saved me. I have not kept that a secret. If it weren't for Mrs. Carr, I'd have been dead long ago. So that is a huge thing. So yeah, let me give a shout out to Mrs. Carr, because it's definitely her who pushed me to take things as far as I wanted to take them, and who supported me through all of it. And there's some dark days here and there in this job. And one thing for you young guys that are thinking about getting married, picking a mate, whatever the case may be, it's not always the best idea to pick somebody who does what you do for a living. And it's not a terrible idea sometimes. It depends on you. But I'll say this. My wife and I have no clue what the other one does for a living. Like, I know where she works.
yeah,
I don't know anything about what she does, the nuts and bolts of it, isn't the same. And the support network that gives you is great, because when my wife comes home talking about work, I don't say, well, did you try this, or you should do this? I go, yeah, screw those guys, baby. I am just unequivocal support no matter what, instead of trying to shoot holes in it. So, that is, I think, like one of the best parts of us is that because my wife has never been a paramedic or, worked in the ER or anything like that, she is a what would you say, an unconditional loving support network, because she doesn't shoot holes and stuff, and then vice versa with me and her. So shout out Mrs. Carr. I can't wait to see you for Christmas. I'm so happy it worked out that I could actually be home this year. I was texting my kiddo last night about it. She's excited. She's happy,
And another thing is, because we travel, they make it possible by keeping our homes in order.
Oh, God, yeah. The hardest job is, and I learned this in the military, the hardest job in the military is being a military wife or a military spouse, because we see the shoe on the other foot a lot these days. Casey, I said her name. She won't mind. She runs everything while I'm gone. So when I'm here and I'm cranking out 12, 13, 14, 15 hours a day, I'm not managing a lot of stuff. My job is to generate income. And I call her the treasurer because I'm really good at making money. She's better at keeping it than I am,
Yeah.
So she balances the books and makes it work. But she not only works a full-time job, not only gets kiddo to school and everything in between. She does it all, in a strong fashion without a bunch of complaining. We both kind of suffer in silence a bit. We confide in each other for sure, but I don't call my wife, woe is me, and, and all that, and drag each other down. And that's a huge part of the support network that, like we talked about in the last episode, in EMS, we really don't have anymore. You know what I mean? Frankly, in terms of this whole team as big as it is, I've got 2 or 3 guys that I call frequently. But I mean, you're the only one I really see. You know what I mean?
Oh yeah, vice versa. Yeah.
And out of the people that we both talk to, it's only the old school ones that understand the value of that. I think guys are throwing away a support network because they like to argue, which is going to be the result of the topic we came here to talk about today. I promise you there's going to be some arguing in the comments about this one.
So anyway, welcome to the Tailgate Sessions with Greg and Gordo. And today's topic is IVs.
Oh, and God, yeah.
I will let Greg take off with this one.
I was talking to Rob about this, and I said, this is something I want to put out there because there's a lot of good information out there. But in my time, in my travels, in my time at the podium, in my time on the truck, I've never seen something people like to argue about more. And I think a lot of them like to argue about it because a lot of us aren't very good at IVs. You know, we're kind of bad at IVs. We kind of suck at IVs. And I was fortunate to have good training on IVs. I was also fortunate to have none of my medical education from the Army count when I left. So when I went through school to be an intermediate and then a paramedic and then on into, I couldn't even drive an ambulance. I mean, the state of North Carolina where I lived would not grant me reciprocity. So I had to work anywhere that I could. Thankfully, in the state of North Carolina, phlebotomy can be done without a license. That is not a licensed profession, or at least it wasn't in those days. Hell, it may be today. And so I had a guy who ran the lab at the local hospital who had worked at MEPS, which is the Military Entrance Processing Station. It's where you go to join the Army, the Marines, all that good stuff. And one of the things they do there is they draw blood. You're going to give a tube of blood when you join the military. They're going to check you for HIV and a litany of other things depending on who you are, where you're from, how old you are. And so there was days I would do 150, 200, sometimes 300 blood draws in a day, and he knew that. He knew I had the experience, so he hired me as a part-time phlebotomist at the hospital. And that job was the most valuable training experience I'd say I ever had because it made me an IV wizard. I mean, it really did. And very quickly, I went from the guy who could get blood when other people couldn't to the person that the nurses would call in the ER and shut the curtain and have me do an IV. Even when I was on duty in the truck, they would say, "Hey, Greg, I'm glad you're here. Will you come with me to 7?" When
I was doing a deployment in Indiana at the ICU for, when the country was shut down, we were running ventilators.
It was good times.
Yeah. The hospital found out that there were 20 paramedics down in the ICU running ventilators, and we were going to floors to do IVs that they couldn't do. Because paramedics can start IVs when others can't.
Yeah, if you get good at hitting a moving target, it's that much easier when they're sitting still.
Or when you're going down the road bouncing or in a ditch when it's dark.
That's a moving target.
A crumbled up car.
Oh,
so
God, yeah.
You asked me my thoughts on IVs. Here's my thoughts. Here's the way I was taught. Start low and work your way up. And I think that today a lot of the students are taught go straight ACs because that's just the easiest vein to hit a lot of times.
Yep.
And that's the easiest way to teach students.
Yep.
However, anytime you attempt an AC and you miss it, you basically, from what I've been taught, you lose all the veins below because you don't want extravasation.
Right. You're not supposed to go distal.
That's right.
That's not saying I've never done that.
Well,
that's a loose.
Same here. Yes.
That's a loose rule at best. You know what I mean?
I say if you put a 4x4 in some Coban tight enough, you're not going to extravasate.
Yeah.
But
that's what it is.
for me, unless we are going to be doing a STEMI alert, a stroke alert, or a trauma alert, I'm going to start low in the hands and I'm going to work my way up.
Yep.
And, if you hit a vein enough, you can piss that vein off enough, it's going to stand up.
And a warm pack goes a long way,
Well, I've never deployed an emergency life-saving warm pack in my whole career. I have deployed an emergency life-saving collar many times, and we'll do that on a mobilization. However, but I always start low, work my way up.
Yep.
And if it's going to be an alert patient, if I'm going to activate it for trauma or for STEMI or for stroke, I will try an AC first. But if I do not get it, I will not go to the other one because my thought process is EMS gets one, the hospital gets a chance at the other.
Yeah.
Because they need that to get patients into CT or whatever it may be, right?
Sometimes an IV needs a chlorhexidine prep to do certain things with. I get that.
That's correct. So for me, I will try to do 2 IVs on all my activation patients. But one of them can be a distal one in the hand. The other one can be in an AC. They like to have 2 sites, but it doesn't have to both be ACs, right and left. But now, if I get a good one on one AC and I see another good one on the other, sometimes I'll bring them in with bilateral ACs.
Yeah.
So, and then when you're talking intraosseous, I'll just say this real quick. A lot of people today are taught to go straight down on that angled bone, and they're not getting into the marrow cavity.
Right.
Always remember that when you're doing a proximal tibia, to aim inward on that flat surface.
Yeah, you need to be, if you're looking at their knee, you want to be about 11 o'clock or 10:30. That's that flat surface. You want to be,
And you
further
go
away
straight-
from
you
the
go
head.
into the flat surface, not straight down.
Right, and you want to be in the marrow cavity, and that's where the tibial tuberosity is, if they're old enough, right? Because you have to begin bearing weight and walking to even have a tibial tuberosity. So that's something to consider in someone who's been, say, a paraplegic their entire life, or wheelchair bound their entire life. Stuff like that matters. But for me, the thing that blows my mind is the propensity to go straight to the AC. Now, full disclosure, nobody wants to argue with a CT tech, so I'll do at least an 18 in the AC for the abdominal pain we can't figure out, or for a lot of the strokes, because they're going to CT and contrast and so on and so forth. But I'd say 99 out of 100 IVs I do are in the hand. I start in the hand, and I can put 14s in people's hands. I mean, one of the things I've noticed is that people don't have a lot of really good experience with IVs. They get out in the field with minimal training, and you do get minimal training in paramedic school, and they hedge their bets. And an IV that is actually extremely easy by the standards of a well-trained and experienced person might be moderately difficult to someone who operates in that way, where they just, they're throwing a hot dog down a hallway. You'll have an AC the size of somebody's thumb, and they'll put a 20 in it because they're comfortable with that 20. That pink catheter makes them feel good. And, catheter diameter matters. We don't have to get into the physics of it and multiply by pi, but like just that little bit of increase in diameter from 20 to 18 is orders of magnitude more fluid that can be flowing through it at lower pressure. So when you're worried about, I did a trauma activation the other day. I did bilateral IVs in the AC. I did 16s. I'm a fan of the 16s.
I love 16s.
Oh yeah, they're great. Why? Because, well, for one, 16s, because there's something magic that happens from 16 to 14 where the vein doesn't want to take the catheter because the materials become thicker. There's that change from needle to catheter, and sort of the way that it pushes, and the skin will grab onto it. With the 16 gauge, it seems like it goes in the vessel a little easier with a little less trauma, and it slides in a little easier, and it just works, and we don't necessarily need that flow difference from 16 to 14. You can do a lot through a 16.
I've pushed a lot of 14s through a vein wall that a 16 would not have pushed through.
Right.
And for that reason, I just totally forget I have 14s on an ambulance. The biggest,
A lot of times I do, yeah.
The biggest I'm going to stick is a 16.
Well, in your vasculature, in a patient who's exsanguinating or whatever, we look at a vein, and in our brain, we think of a vein as being round. But whenever someone's bleeding or dehydrated or they have really low blood pressure, that it's oval shaped, it's flat, right? So you don't have a vein that goes this deep it's like this. And to get that full bevel and the piece of the catheter in that vein, it needs to be so deep, right? And it may not be that deep on a 14, but if you look at the dimensions of the 16, that little bit, smaller, shorter bevel lengthened catheter just fits the average human anatomy better, because most people don't have super huge veins. Now if you lay block or work for a living, or if you work out or pump iron and you got big veins, you could put a 10 gauge in there in theory, but the 16 works. And I'll do an IV in the AC if I think there's imaging or a reason for it. But it's not a good IV for flowing things by gravity, which in EMS we do, because any little movement changes your flow rate, right? So when we're trying to use pressor agents like dopamine, or a lot of people forget, after a cardiac arrest where you had ventricular dysrhythmias and you're supposed to cook up that 1 milligram a minute of amiodarone, your flow rate changes. Stuff like that is essential to the gravity flow, that there's like a consistent amount of resistance, and it changes every time they move their arm when it's in the AC. So I like a place that's not mobile, and I'm always going to start there. And I think the reason, and this is what pisses everybody off, the reason most people don't do it is because they're nervous, it's harder, they're afraid to miss, they're poorly trained. They know they can put a 20 in a giant AC, and so they go for it. And personally, that's a waste of an IV site. You should be putting what the patient needs in a place that, in many aspects is convenient for them. If I see somebody who's going to have a couple of days worth of stay in the hospital, the COPD patient that waited too long, you know, or any number of things. I'll ask them, are you right-handed or left-handed? And I'll put it in their non-dominant hand. Why? Convenience. They're going to spend 3 days in the hospital. I'm thinking about what this experience is going to be like for them. That's obviously for a patient who's not dying. And the vast majority of our patients are not dying. Yeah. So if you're dying, I go where I can go. I'll put it in your neck, whatever the case is. If you're not dying, and most patients aren't, I spend the time looking for a convenient IV site and that's good practice. So do you do that? What do you think?
Well, yes, totally. Just exactly what you said. But let's also talk about, and I know we only have a few minutes left, cardiac arrest. Everything in your extremities shut down. Yep. Everything goes to your core. Mm-hmm. So I don't understand why we're doing IOs as a first line site in the proximal tibia when we have to put a pressure bag on it to even get it to flow. Yes. And it's in a distal extremity that's being shut off due to a shocky state.
Yeah.
AC, but even more preferably, I love jugulars.
Oh, yeah.
And you can drop a 16 in a jugular if you need, real easy. And I think that's something that we as a profession have got away from is jugular IVs. But in cardiac arrest, I want a vein. I don't want a bone.
If I can have a vein in cardiac arrest, 100%. And you know what? With good CPR, especially with a Lucas, man, you can get enough venous return that jugular, that external jugular will pop out, especially if they're even the least bit lean. And you know what? A lot of them are, because who do we work cardiac arrest on? Very old, sometimes cachectic people who should have a DNR but don't.
Yeah, but most people have a jugular anyway without CPR. If they're laid flat and you turn their head, they got a big jugular. Yeah. And don't be afraid to hit that. I think that is an amazing, it dumps right into the circulation. You're going to get better effect from your fluids, your medications, everything. And that's where I stand on IVs. So I'll let you close this out. And
So I'd love to hear what you guys think and why, because I understand that I'm not running every call out there, and your experience can be something that fools you. But with that said, guys, let's hear what you think, and in the meantime, get out there and practice. Rob?
Well, normally I say you don't have to be the best, just do your best. But hey, let's do a public service announcement.
Okay, hold on. Here we go. What are we doing?
Don't forget to spay or neuter your pets.
Yeah. Or some of your relatives. We need the reduction in call volume, guys. We're tired.
Yes. We'll see you next time.
All right, guys, be good.